Welcome to this edition of EAU TV. My name's Tim O'Brien. I'm a urologist in London. And with me I have Patricia Zondervan, who's a urologist in Amsterdam, and Evangelos Liatsikos, a urologist in Patras in Greece, who's also head of the ESU school. And we're here to discuss the highlights of day 2 of the EAU meeting. And there has been a strong surgical theme in day 2. The medico-legal session this morning called Nightmares in Urology. And then in the afternoon there's been a rich vein of live surgery. So Patricia, maybe I can turn to you first. The nightmares in surgery, I think there was quite a lot of controversy around a case of partial nephrectomy with some complications today. How did you see that case panning out?
Yeah, well, that was, I think, something we could face all, so it could happen to us all. And I think that, well, the discussion is about informing the patient partial nephrectomy versus radical nephrectomy, and then facing and balancing the complications.
If you didn't see the case this morning, the surgeon cut into the tumor was released into the perioperative field, and then the patient developed recurrence. And they developed recurrence because of surgical error. And it was about the strategy to avoid that, and not particularly about how to manage it, was it? But about how to avoid that. How do you square that circle with the patients you see?
Well, I always discuss the pros and the cons, and I make the balance. Well, we have the multidisciplinary tumor board team in which we discuss which options are available or we advise for the patient.
Okay, so that was quite a strong theme. There was a lot of discussion from the floor about that, about does every case need to go through a tumor board, an MDT? There was some strong feeling from the chair and the person discussing the case that was not the case. The case just needed to be managed according to guidelines. But in your practice in Amsterdam, is every case goes through a tumor board?
Yeah. We have we founded a kidney cancer network in Amsterdam with the Dutch Cancer Institute and the OVG, and then our Amsterdam University Hospital, and we discuss every case. So we also committed to each other that we should any patient which has the suspicion of a renal tumor has to be discussed over there, and we do. Yeah.
I think it can give confidence to a patient, can't it? You tell a patient, this is what I think should happen, but we are going to discuss this in our tumor board and our MDT to confirm that the decision is correct.
Yeah.
Because they don't really know you or about your decision making. Yeah, I think it is. There was certainly some strong opinion from the lawyer, Bertie Lee, that should be the case. I think it probably particularly helps if there are complications, doesn't it, that we're doing the right thing. Do you discuss radical nephrectomy with every patient who has a small renal mass or not?
No, not the small renal masses, but the T1Bs. If the patient is much older, has a good renal function, and then facing possible complications you could get from a partial nephrectomy, we always discuss,
Do you? Yeah. Evangelos, how do you see that particular dilemma panning out?
I think that the oncology board is something that adapts to the different countries. In some countries it's more feasible, other countries it's not. In my country, you wouldn't do an oncology meeting for a tumor in the kidney unless for a small renal mass. On the other hand, I will inform my patients that the partial nephrectomy, any partial nephrectomy, could end up in a nephrectomy in case of some kind of bleeding that I cannot control. I do this on my private and on my government university clients, because I feel that if it ever happens to me, I want to be covered. I won't have to inform them, because I don't have that time to go out and inform the relatives once this happens. I mean, and problems do happen. Now, my question would be, if this would happen in a scenario like this by a foreign surgeon. So, if the surgeon was someone who was a Greek guy operating here, I mean...
Oh, in live surgery?
In live surgery.
Yeah.
Okay.
So this would be interesting to see how, I mean, because this is the
Right.
whole.
That introduces a whole new level of complexity, doesn't it? Maybe we can come back to that when we
but this
talk
is
a bit,
an
certainly
interesting
that
point.
is very controversial. I completely concur. So are you looking forward to being one of the victims of Bertie Lee next year in the Nightmares in Urology session when you're up on the...
No, I've looked at you, but I think you have been challenged. I think it will be very difficult.
I think there are different levels you can reach in surgery.
Yeah.
One is doing the operations, and then
Yeah.
one is being grilled by Bertie Lee about the operations. I think there are these moments in your career.
Yeah.
But I must say, it's
Is that
better
my
to be
issue?
drilled here than be drilled in
Yeah.
in court.
That's true.
It's,
That's true. I think
Yeah.
one of the very good themes that did
Yeah.
come out of today, which I definitely took out of today, that I think if a surgeon is going off-piste, if you're doing something unusual, then the level of care that you need to take around documentation and conversation with the patients was huge. If you're going off-piste, doing something unusual, developmental, innovation, introducing something new, then the type of conversation you're having with the patient needs to be on a totally different level from one where you're doing something completely within guidelines. And I think I definitely took something out of that. Well, the case I got grilled on was cytoreductive nephrectomy, and you were doing a cytoreductive nephrectomy this afternoon in live surgery. So have you worked out your thoughts around the indications for cytoreductive nephrectomy and how you square that circle?
Yeah, well, the difference was that you performed an upfront cytoreductive nephrectomy, and I did a deferred cytoreductive nephrectomy.
Okay, so your patient has had
actually,
systemic
it
treatment.
was all in the files in the MDT team. No, well, this was actually a poor risk patient, upfront metastasized, and she got immunotherapy, and then after 9 months, she had complaints of hematuria, and actually the metastasis disappeared, and not all, but the others were stabilized. The tumor, the primary, was growing, so actually it was a good indication. And these are the good responders. Well, we know you can offer them cytoreductive nephrectomy.
And is that now the majority of your cytoreductive practice in Amsterdam?
Yeah.
It's people who've been treated and have stabilized?
Well, I have some cases, like an 18 years old, a very young guy from Syria, which had a very big tumor, like 30 centimeters, and then a solitary mass in his liver, which you could resect very easily. So, you know, these are the good prognosis.
Okay, so I'm going to slightly pin you down on this. So how do you decide, in that a new situation of cytoreductive nephrectomy, how good does the response have to be in order for you to then move forward and do a cytoreductive nephrectomy?
So you mean deferred cytoreductive?
Yeah, I mean, how much response do you need to see in order to justify doing it?
The policy, or our policy in our team, is that the metastasis has to be stabilized. They should not be growing, and the primary has to. You see, like in the beginning, it decreases, and then suddenly you after 9 months or something, you have an increase of necrosis. And the tumor is growing while the metastases are going down. So that is the moment, the window you can offer deferred cytoreductive nephrectomy,
that's interesting.
in my opinion.
Good. So Evangelos, you're in charge of the European School of Urology. You organise the live surgery. Patricia's doing live surgery. Quite a controversial area of Congress management, isn't it? Live surgery. I mean, how do you manage that whole?
I'm a big fan of live surgery.
You like
it?
it?
I think that the people want live surgery, and they do not want the sterilized view of a pre-recorded surgery, because unfortunately, in a pre-recorded, everyone wants to show the best of what they're doing in the best clinical scenarios. This is instructive up to a certain point, but not in the full scale of what the people want to see. So the question is, how do we make it a safe approach? Okay, because we all know very well that years ago, you used to travel everywhere and you used to operate everywhere, no limitations, no rules, no guidelines, no nothing. In the EAU and in the school now, we have live surgery guidelines and restrictions and rules that everyone that is organizing a live event need to fulfill. Patient advocates, for example. There is always a patient advocate, which is a local surgeon inside the room. If they consider that what you're doing is not safe, you stop your surgery and they take over. They are the local people.
you think this genuinely does increase safety, or do you think it's just window dressing?
Well, it's not window dressing. It increases safety at a point where you cannot, if you do something really wrong, you faint or you whatever, you know, they take over.
So there are some safety mechanisms.
Yeah.
And you mentioned earlier about surgeons coming in and doing live surgery and making mistakes. I mean, how...
First of all, it's very important that you get your consent with your patient. And the patient knows exactly who is operating him and you know who's responsible. And there's also a backup surgeon. So every case that you saw today had a surgeon operating, a surgeon responsible of that case, and a patient advocate.
A local surgeon who is responsible.
A local, exactly. Okay. So the patient we met the patients the day before. We go through the cases.
Okay.
We tend to give cases that are not extremely difficult. They are more or less, you know, normal cases in brackets. Nothing can be normal in reality. This has been the phase that we are now, but I see this as evolving in the future. I mean, now with technology and with telecommunications and with 5G and with internet speeds, I would think that it makes more sense for me to operate from my institution in Greece and transmit, because this gives you a lot of, first of all, the responsibilities.
But the problem is you can't be at the Congress. You can't be at the Congress if you're in Patras.
You come the day after, or you come, you know, as it consider that your flight was cancelled.
And why not just use faculty from Amsterdam? Are there not enough good enough surgeons in Amsterdam to
it's clearly a mixture. It's really a mixture. So the local people here are going to be doing the cases, and some other people are going to do cases from abroad.
Okay.
And then you fly them in.
Okay. So what case did you do today?
I did a ureteroscopy today.
Okay. For a stone? Or
for a stone, yes. Okay. For a stone. So as I said, and the plus here is that you can also do extreme cases, because if you're at your own facility and you're at home, you can do any case that you would do anyway, because you have your nurses, you have your facilities, you have everything there, which you're very, and you have also the responsibility, the legal responsibility at the end of the day of what is being done. So I think live surgery will slowly move towards that direction. I mean, local faculty doing the cases here, and the rest, selected surgeons around the world, maybe in China also, or maybe in Canada. Yeah, we see now that with the speed of communications, this is, you get a perfect video, a perfect one-to-one communication. So I think live surgery will stay, even though a lot of companies are keen on the pre-recorded concept, because they want to show their equipment at the best.
So, okay, let me just pin you down on that. So you're interested in it as an educational tool. Why don't we record and edit and show lots of different, so say the apex of the prostate, why don't we record 5 different dissections of that and show the different elements of dissection, so one can really zero in on particular concerns around.
This is a webinar. This is a webinar. So when we do webinars, and we do a lot of e-classes now and in webinars, and we have a huge portfolio of web events.
Right.
So you make a webinar on apical dissection, and that's what you do. You put your apical parts inside.
A different product.
Exactly. Okay. But you know, all the live meetings that are out there, they have clients that are clients in brackets. I mean the doctors that are really very enthusiastic about this, because they see how the expert reacts in something unexpected.
Okay.
This is very important. I will never forget, for example, when I was younger, I was in Bordeaux, and I saw on a live case, they made a French team in Bordeaux, so there was a local team actually there, that they injured the aorta laparoscopically. And they fixed it.
Okay.
And they fixed it. So that for me was a huge lesson. It really changed the concept of how we're seeing things. So I want to say that live surgery has a huge input.
So, well, you're in charge of it all, so you're going to keep it at the EAU meeting, are you?
Yeah.
Yeah, okay. Do you think there should be live consultations as well?
Why not?
Well,
yeah, no, it's an open discussion. Whatever.
It's one of the things that I talk about in our department, that with senior surgeons, we spend hours watching young urologists operate, and we spend no time at all watching them consult. There are lots of registrars in the department of guys who I've never seen do a consultation, have no idea how they frame questions, how they sit, what their body language is like.
You know, the patient office now is a very active part of our organization, and a lot of the needs of the patients are going to be coming into all the rest of the offices, including the school. Yeah. So this would be a very interesting idea to see how we react with the patients, the young guys react, and vice versa. How all this is.
And do you have basic? I mean, does live surgery tends to be the big operations, doesn't it? Do you have basic sounds wrong to say basic, but more straightforward operations in the live surgery program, say a prostate biopsy or things like that?
We don't have prostate biopsies because this is considered to be a diagnostic part. Right. So the live surgery here is a full day of, and we try to cover oncology, stones, BPH. So we try to cover the operative part, let's say. We don't go into focal or into, I mean, this would expand the day. Okay. We might be in the future, because people, the room was full in the morning. So it means that people have always been interested in this kind of...
yeah, no, it's definitely popular, isn't it? Yeah. Did you enjoy doing your case?
Yeah. Besides the organization, the local organization in our hospital, which was also quite a
They
challenge.
did a great job on the organization.
That was nice. Okay. Well, yeah. Well, I think, which is very important, there are two ways to do live surgery. Starting live or on air from the start of the beginning of the surgery till the end. So you are the whole surgery, like an Eurocheck, then you have the whole surgery. And during this Congress live surgery event, you have only a small part. So you can just relax and prepare the things to explain, do some small surgical steps, and then it's done. So it gives a relief of, it gives less stress, I think, in my opinion.
Did you feel calm?
Yeah, actually I felt, yeah.
Because I don't like distraction when I'm operating. I don't like things. I never look at email on days I operate, for instance. I just don't like any distraction. I'm concentrating. Is there a lot of distraction on a live surgery day, which is potentially making you not concentrate on what you're doing? Or?
No.
You were just focused.
And the key point here is the organization. So the day before, we meet with everyone. We meet with the doctors, the patients, the companies. So we make sure that everything is there. We make sure that the doctor that is operating has all he needs to feel confident with what he's doing. We show him the case. The case is studied. So everything follows rules.
Yeah, and I think the most important is that we have the local surgeon, which is just like acting like he's the normal surgeon, like the patient file. So you got a script now, positioning. So everything is arranged accordingly.
And everything is in direct communication with the patient. I was yesterday. I was amazed, and they have a perfect organization here in Amsterdam. Everything is so structured, and everything follows the rules as it should be. So everyone felt very secure today when.
Everyone in the Netherlands follows the rules. I thought
in the Amsterdam.
I thought everyone
in the hostel I saw today.
I thought Dutch people were all about not following the rules.
No, the
being
hostel
free
is something
spirits.
else, Tim.
Okay, right. So you follow the rules where you need to follow the rules. Okay. Oh, that's good. Yeah. And have you ever been grilled by Bertie Lee?
No, but I would be thrilled to do it.
Maybe it's your turn next year. The Nightmare in the Stove.
I'm studying law also, so it would be very fun, to do that. So I would be
interesting to see him.
I would love to be the victim.
Yeah, well, it's interesting. It was interesting seeing Peter Albers today, who is obviously an extraordinarily eminent urologist, and it was interesting. He was very brave. The case there was some problems in the case he presented, which was his case, and it was interesting to see him. Obviously, as someone who speaks English as their native language and is English, it's a challenge. It was a challenge for me today. I'm astonished that people are able to do this, be interrogated by a lawyer in a language that isn't necessarily their own. I mean, it just completely...
No, but it's very instructive. It's very instructive.
Yeah, and he's really goes very deep.
Yeah, no, it's quite an exercise. I mean, Peter's case was interesting because he was doing something quite innovative, and we covered the issues around how do you innovate safely. And I think there's been quite a bit, as a Congress, that's quite an important issue, isn't it? How do we introduce the new safely?
It's a big discussion because all the new have a CE mark.
Everything around here is new, bigger, better, new, try this. How can we make sure it's being done safely? So what's your take on that?
Well, I think...
In your department, maybe.
Yeah, everything is well structured and has to go through all these authorities, and so that is really very well back up. How do you say this?
Yeah, back up. Yeah, okay.
So there's
you have to follow certain rules because anything new, you can't have experience on something new, and this has nothing to do with live surgery or not, because even if you're in your own institution, you try something new, you need to be backed up by a protocol, ethics committee, everything that the law says that you need to be doing on a CE-approved product, because it's a CE-approved product. You have a device that has a CE mark, and it has license to be used on patients. So there it's up to your ethics and your experience. Inform your patient. Clearly, if your patient thinks that he's being operated with something that has a huge, experience in medicine and it's been there forever, this is a misleading to your
I mean, Mesh had a CE mark, didn't it? Did Mesh have a CE mark?
Yeah.
I think.
Yeah, I know.
And
that's what I'm saying.
That created some trouble, didn't it? Yeah. And was your case robotic today?
No, it was laparoscopic.
It was laparoscopic.
Yes.
Have you seen? Are you going to be trying the new robotic platforms? Have you? It's been a feature of the surgery here, isn't it? The availability of new robotic platforms.
I've been to Orsi to go to.
So that's something that you're interested in. Yeah.
Well, everything is interesting, I think. New innovations.
Yeah.
Because we have to be ahead of.
Stay ahead.
Because otherwise we will.
We are using the Avatero robotic system now in Greece. We have it in the department, and now we're doing the first clinical cases there. It's nice. It's a very nice period right now, because you have so many competitive products on the topic of robotics that's only going to make things much better. And
might be a theme for the live surgery next year, is the new systems.
Yeah.
Because a lot of people will be interested in.
There was already a session today. In fact, I come from that session where we saw the Kawasaki robot, a pre-recorded video. It's amazing robot. If that gets a CE mark, it will really make the difference, I think.
Okay.
We saw the Hugo. We saw the full range of what is out there right now, and every year we'll be seeing more and more of that. And I like that. It's a thrilling.
A nice aspect of our specialty, isn't it?
Yes.
I gave a talk, I just finished as the president of BAUS, and I gave a talk at the BAUS meeting, and one of the things I talked about was the advent of technology in our specialty. When I qualified in medicine, there was no CT scanner at the hospital in Oxford where I qualified, and the flexible cystoscope was still 1 year away from its debut. So it's amazing. Now, I'm 59, so in just the career, in the generation of one urologist, everything has changed. It's amazing. I think the other thing is that it won't stop, will it? The advent of technology won't stop. I mean, the next 30 years, there'll be another whole raft of technological innovations.
Perhaps we don't do any surgery anymore in 50 years or something.
Stones will be there.
Yeah, stones okay. So I choose the wrong.
Maybe the surgery goes. What do you think the big technological innovation will be when you're old and crusty like me, and what would you think?
Probably we will radiate and targeted therapy, specialized, personalized, or whatever, combinated, something like that. I don't know.
Yeah, I think there'll be more. I agree. There'll be more targeted. I'm not sure there'll be a lot of surgery for the small renal mass.
No.
I think a lot of that will be targeted and ablated.
When we talk about what happened in medicine 40 years ago, and it's not so far away. I have my teachers used to tell me, older urologists in Greece, that they were doing open adenomectomies with no sutures, no cautery, and they used to take out the adenoma, and then they used to put some gauzes, some tampon gauzes inside, keep the wound open, and then on day 3 they used to pull it out. Mortality 50-60%. And that was 40 years ago. Development is condensing the period of development. So in 5 years from now, it will be completely different so by the time we retire, I think that we will be laughing in brackets with what we did when we started our careers.
Do you think there'll still be congresses in 40 years' time? Do you think there'll still be?
I think so. Yes, not many, but they are still going to be the hubs for socializing, because I think that the congresses is not only the scientific, it's also the social part. You get to meet your colleagues.
The networking.
From all around the world, and look at this year. We haven't been traveling for 2 years, and everyone is thrilled
to
now.
have contact.
I think we should be unashamedly promoting that aspect of it. That it's as much about the networking and the conversations and the relationships and the friendships as it is about the lectures that one goes to. So I think there probably will be congresses, won't there? But I think they'll probably be different. I think we should wrap things up. Thank you very much for your insights into the day. Medical legal, live surgery, medical legal, all those things melting together. And I hope you've enjoyed this episode of EAU TV, and hope you enjoy the rest of the Congress.